Good morning, everyone. Here is your lecture on kidney and urinary tract disease, or the renal chapter. So first of all, sorry about this being late, and second, if you hear a lot of background noise, I apologize. My husband's outside working in the yard, and the neighbor dogs like to literally bark at absolutely everything. So y'all just bear with me. All right. The quick overview of the kidney anatomy. So we have two kidneys, two ureters, a bladder, and a urethra. The functional unit of the kidney is the nephron, and hormones that are involved in water balance and influence the kidney are renin and aldosterone. And so aldosterone, under the control of renin, regulates the reabsorption of sodium and the secretion of potassium. And the way that works is it will reclaim sodium from the urine back into the blood. And as it moves sodium from the urine filtrate back into the blood, it dumps potassium, but then also water follows the sodium. So moving sodium is a way to move water. And that's what aldosterone does in response to renin. Now, antidiuretic hormone is another hormone that influences water balance in the kidneys, but the difference between aldosterone and antidiuretic hormone is that antidiuretic hormone moves water without moving sodium. So antidiuretic hormone opens up aquaporins that allow water to flow from the filtrate back into the blood, and so it concentrates the urine and dilutes the blood. And so, and again, it does that in response to like maybe dehydration. Both of them can respond in cases of dehydration or low volume and stuff like that, but they each have a different action. All right, the primary function, of course, of the kidneys is homeostasis. Its job in homeostasis is the removal of waste products, retention of critical nutrients, acid-base balance, and water and electrolyte balance. In addition, the kidney synthesize erythropoietin and renin and vitamin D, which are all hormones. And yes, vitamin D really is a hormone. Erythropoietin controls the production of red cells, and then renin helps control blood pressure and water volume. And then vitamin D is activated in the kidneys, and it helps with calcium metabolism, but also many, many other things. All right, so urine is formation starts in the glomerulus. So then the glomerulus is located in the cortex of the kidney, so that's kind of like the outermost portion of the kidney. And the filtrate from the blood is captured in Bowman's capsule. And that filtrate then is going to travel through a system of tubules, starting with the proximal convoluted tubule. It's proximal because it's the closest to the glomerulus. Then it goes down the loop of Henle, also known as the nephron loop. So it goes down and then back up, and then it goes through the distal convoluted tubule. It's distal because it is further away from the glomerulus in the path. And then from it, the filtrate, which then becomes urine, is dumped into the collecting ducts, and then the collecting ducts are going to carry the urine into the renal pelvis and stuff. So I did note here the glomerulus and proximal convoluted tubule are usually located in the cortex, but a loop of Henle, distal convoluted tubule, and collecting ducts are closer to the medulla. But anyway, so that kind of gives you an idea. Uh, all right, so if you look at it here, what's going on where, and so here it is actually put in a straight line. Y'all know, I'm sure from other pictures of the nephron, this is not the case. It's not in a straight line. It's convoluted. It means it's got lots of twists and turns. But let's just, if we took it and flattened it out, we could see kind of what happens where. So the glomerulus with Bowman's capsule. So this glomerulus is right here. It's a ball of capillaries. Bowman capsule is right there capturing it. So there's blood here, and there's high pressure that's created, and that allows the liquid portion of blood basically to filter out. So this is filtration right here, filter out, and this filtrate then enters the proximal tubule. In the proximal tubule, because this is filtrate of blood, there's a lot of very necessary components that are in there that need to be put back into the blood. So that's why we have reabsorption, and it reabsorbs the majority of sodium, glucose up to 180 milligrams per deciliter, potassium, amino acids, bicarb, phosphorus, urea, and water. But the ADH is not required at that step to reabsorb water, so it does it automatically. And you can it can start secrete hydrogen ions and foreign substances. The loop of Henle. Sorry, I was throwing a pillow at my dog. The loop of Henle concentrates the urine. That's the process starts there. In the descending loop, water is reabsorbed and sodium diffuses in. In the ascending loop, sodium is reabsorbed via active transport and water stays in. And you have urea secretion also in this thinner segment. So in the proximal tubule, the filtrate is acetonic, and in the loop of Henle, it starts acetonic, then it goes hyper, then it goes hypo. And the distal convoluted tubule, you have the reabsorption of sodium, water, and bicarb, but ADH is required in the distal tubule to reabsorb water. And then you have the secretion of potassium, urea, hydrogen ions, and ammonia, and some drugs and stuff. And at this point, it can be acetonic or hypotonic depending on your level of hydration. And the final concentration happens in the collecting duct. You have a final reabsorption of water, but ADH is required for that. And then reabsorption or secretion of sodium, potassium, hydrogen ions, and ammonia, and urea absorption in the medulla. So that gives you kind of a snapshot here of where things happen. Okay, so basically, urine is formed in this way. Substances that have a molecular weight of less than 70,000 Daltons, which is water, urea, creatinine, and all that, will pass through and be excreted. So that means all of those molecules are small enough to leave those capillaries and enter Bowman's capsule. And so basically the glomerular filtrate is plasma without proteins or fats because they are bigger than 70,000 Daltons, especially albumin. So albumin, that's why albumin is not supposed to be in urine, because it's actually a bigger molecule, and it shouldn't be in there. Okay, so most of the glomerular filtrate is reabsorbed into the blood because it's all stuff that was from the blood that needs to get back into the blood. And the reabsorption, as we just saw, begins in the proximal convoluted tubule. 80% of the fluid and electrolytes filtered about the glomerulus are reabsorbed, and the rest is eliminated. There is a limit of how much an analyte can be completely reabsorbed. We saw that with glucose. And so we know we use it because we know the threshold that's in it. You guys can relate to it because we test for glucose and stuff. So anything greater than a blood of 160 to 180 milligrams per deciliter in the blood will start showing up in the urine, which means that all the way up to basically 160, 180, your urine glucose is going to be negative. So if your patient had a blood glucose of 200 milligrams per deciliter, then you would expect to see a positive urine glucose. And of course, then the higher the glucose, the higher the urine glucose will be. Then there are secretion of waste, of course, that happens, especially in the proximal convoluted tubule. Hydrogen ions can be secreted in exchange for sodium ions, which means it would dump hydrogen and reclaim sodium. The descending loop of Henle is a concentrating portion, and it's freely permeable to water, but not to the solutes. And the ascending loop is the diluting segment, and it secretes sodium and chloride, but prevents water loss. So each part of the loop has its own function. The distal convoluted tubule have two main functions: the final reabsorption of sodium and the removal of excess acids from the body by dumping a bunch of hydrogen ions. The collecting ducts are the site for the final concentration of urine. This is its last chance to do anything to it. And again, in that portion, in the distal convoluted tubules and collecting ducts, you must have antidiuretic hormone to reabsorb water. And again, that helps prevent excess excretion of water. All right, so let's, I've already alluded to this, but let's go back over how this is all regulated. So your renin, angiotensin, aldosterone pathway. So renin is secreted by the juxtaglomerular cells in response to decreased blood pressure or decreased sodium concentration. And that's decreased sodium concentration is actually, in the blood. So it senses the juxtaglomerular cells are right there by the glomerulus. There's a portion in the nephron where after the loop of Henle in the distal convoluted tubule, the beginning of the distal convoluted tubule, it like loops close to the right next to actually the glomerulus, and that's where these juxtaglomerular cells are located. Anyway, so think of them as sensors, okay? So renin converts then to angiotensin. So renin is released by the juxtaglomerular cells. It is converted to angiotensinogen. Okay, I'm sorry. It converts angiotensinogen to angiotensin is what I meant to say. Angiotensinogen is always present in the blood. The liver makes it, and because it's the ogen word, that means it's the preform. It's inactive. It doesn't have. It's waiting to be activated. So renin activates it, and it becomes angiotensin 1, and then angiotensin 1 is converted to angiotensin 2. And actually, that happens often in the lungs, but in all kinds of other places in the body too, not just the lungs. All right, so then angiotensin 2 stimulates aldosterone. Aldosterone is secreted, as we saw on Tuesday, by the adrenal glands. And so the adrenal glands will be stimulated to release aldosterone. And then aldosterone is going to go over to the kidneys and promote the active absorption of sodium in exchange for potassium, which means that for every sodium molecule that moves from the filtrate back into the blood, it will get rid of a potassium from the blood into the filtrate. So it has to do this equal exchange of positive for positive ions. And so the net effect is an increase in plasma sodium. And as you increase the plasma sodium, then you increase the plasma water, because water always follows sodium. And then you'll get a decrease in plasma potassium. So this is where sometimes you have like dehydration. You can easily have a low plasma potassium because your body's making aldosterone to try to reclaim the sodium in the water, and in the meantime it's dumping potassium. So a lot of the electrolyte replenishing drinks have potassium in them along with some sodium. Okay, then antidiuretic hormone works separately, but it has the same goal as one of the same goals as the renin, angiotensin, aldosterone pathway is it is in response to increased plasma osmolality that it is released. So basically, your blood is too concentrated; it needs more water, and therefore ADH what is going to be produced, and it will make a more concentrated urine because it's going to move water from the urine back into the blood. So the point of ADH is to simply dilute out your blood because your blood's too concentrated, and so it's going to do that by concentrating your urine. So again, antidiuretic hormone, as we saw on Tuesday, is produced by the posterior pituitary, and it is, again, secreted when your plasma osmolality is higher than necessary. All right, let's talk a little about protein conservation. So most proteins that are less than 70,000 Daltons, of course, are reabsorbed. The ones that are greater than 70,000 Daltons, of course, shouldn't even be filtered. Okay, so what would cause proteinuria? glomerular disease, so any damage to the glomerular basement membrane. So because it's damaged, then bigger molecules, like the bigger proteins, can make it through into the filtrate, and then there's not a system to reclaim them because they're not supposed to be there. Okay. And then there's an overflow mechanism for those that are small. The renal threshold for protein is exceeded, and that's when you see the Benz-Jones protein into the urine. So that's another mechanism. So if you are producing a lot of the smaller proteins in abundance, then they will spill over into the urine the same way glucose spills over in the urine when blood glucose levels are really high. So and then a third one would be tubular damage. So instead of being glomerular damage or overflow, we're into the tubules. And tubular damage can be caused by drugs and by lack of oxygen. So we have circulation compromised in the kidneys. TAM horsefall protein is secreted by the kidneys, and it's possibly to help prevent kidney stones, and an excess of the TAM horsefall protein makes cast. All right, so let's talk a little bit about acid-base balance, another very critical function of the kidneys. The kidney buffering and acid-base balance is a slow process. So if you go back and review acid-base, you'll remember that your bicarb system is your fastest and your first line of buffer, and then the respiratory system is the next fastest to help compensate. But the kidneys are important. The process is slower. So the kidneys contribute to acid-base balance through tubule mechanisms, so they can excrete acids or alkali to maintain pH. So this is the great thing about the kidneys is whatever's in excess, it can help dump it out. Okay. So the excess hydrogen ions can be excreted in the proximal convoluted tubule, and those excess hydrogen ions can either form acids or ammonia in the collecting ducts. And then it can also reabsorb bicarb. So bicarb is necessary in acid-base balance because your bicarb can pick up excess hydrogen ions to be converted to water and CO2. And so, like if you have a metabolic acidosis, it's your bicarb is being used up by combining it with hydrogen ions. So we really need to keep as much as possible of these bicarbs. So the kidneys have a system to reabsorb as many as we can. So so the bicarb reabsorption happens again into tubular cells, and it can basically the bicarb, you add hydrogen from the filtrate, it becomes CO2 in water, and then CO2 in the tubular cells, and the CO2 enters into the tubular cells, and the OH hydroxide ion is added, and that becomes bicarbonate, and that can enter the blood and circulate and function as bicarbonate. So again, the three main hormones produced by the kidneys themselves. So if you will, you can kind of think of the kidneys as part of the endocrine system, even though we didn't talk about them in the endocrine system. So the three hormones that are produced by the kidneys themselves are renin, from part of the renin, angiotensin, aldosterone system. It reabsorbs water and sodium and increases blood pressure when the blood pressure is low. All right, the other one is erythropoietin, and it triggers red cell production. So the peritubular cells of, so the tubular cells, they're the cells around the tubules, if they sense anemia or hypoxemia, so basically they're sensing not enough oxygen arriving into the kidneys and stuff, and that could be because there's problem with blood flow to the kidneys anyway, so, or there's not enough red cells carrying that oxygen to carry the oxygen, so anemia or hypoxemia, then it will trigger the release of erythropoietin, and erythropoietin will go to the bone marrow and cause the formation and release of more red cells, and more red cells means more oxygen carrying capacity, so that in theory would then increase the oxygen levels to the kidneys. And then calcitriol is vitamin D3, is this other name, and also so it's also known as 1,2,5-dihydroxyvitamin D, and it regulates calcium absorption to maintain calcium levels into the blood, and it is regulated by the parathyroid hormone. Okay, so let's get into imbalances and disease states and stuff. So uremic syndrome is characterized by azotemia. Azotemia means you have a high BUN. BUN stands for blood urea nitrogen. And uremic syndrome commonly develops with chronic kidney disease, but can also occur after an acute kidney injury. The definition of kidney failure is a glomerular filtration rate of 15 mL per minute per square meter or less, or a creatinine clearance of less than 10 mL per minute. Characteristic lab results of uremic syndrome and kidney failure is a BUN greater than 50 milligrams per DL, a creatinine greater than 3.0 milligrams per DL, and a potassium greater than 6.5, and a hemoglobin less than 10. And of course, if you think about it this way, so the kidneys are failing, so they're not excreting the waste products, which are BUN and creatinine. Aldosterone really has no effect because it's not, kidneys are failing, they're not working. So you're not dumping potassium anymore. So potassium will accumulate in the blood. And the cells that are normally producing erythropoietin are not working. So your hemoglobin is going to drop because your amount of red cells are going to drop. So that's the characteristic lab results there. The treatment options are dialysis and transplantation. Glomerular nephritis is the next condition we're going to look at. Inflammation of the glomerulus is glomerular nephritis. It is often caused by a post-streptococcal infection. That can be acute or chronic of onset. Acute obviously means it happens really quickly, and it's usually very quickly after a strep infection. Chronic takes a longer time to develop. And it can be primary or secondary. Primary glomerulonephritis means that it's the glomerulus is inflamed, and that's just the primary disease. The secondary is obviously it's like a side effect of another disease. So here, for example, the post-streptococcal infection, that would be an example of a secondary one, because the primary problem was the strep infection, and then the glomerular nephritis came secondary to that, came because of that. So some of the causes of glomerular nephritis, so group A strep infection, which is strep throat, amyloidosis, endocarditis, Goodpasture disease, mono, and lupus. And there's many, many more. And excessive use of NSAIDs. So NSAIDs are non-steroidal anti-inflammatory drugs. So you think in your like ibuprofens and things like that, aspirin, all of that. Signs and symptoms of glomerulonephritis are proteinuria, edema, hematuria, oliguria, and high blood pressure. So that's protein in the urine. Edema is swelling. Hematuria is blood in the urine. Oliguria is a small amount of urine produced. And then high blood pressure, that would relate with the edema because the fluid is not coming out. You're not producing urine, and all your fluid is staying in the body. And of course, a high BUN and creatinine indicating the problems with the kidneys. All right. The next one is nephrotic syndrome. Nephrotic syndrome has several underlying conditions, usually due to an injury to the glomeruli, and diabetes and lupus are some of the most common underlying conditions of nephrotic syndrome, and we know how prevalent diabetes is. The signs and symptoms of nephrotic syndrome is heavy proteinuria. So there is a lot of protein in the urine, and that's one of the hallmarks of nephrotic syndrome. This is this massive loss of protein, and it's so massive that it leads to hypoalbuminemia. So your amount of albumin, which in your blood, which if you remember, half of your blood protein is albumin, and so because you're losing so much of it, the level of albumin in your blood drops and it all shows up in the urine. And then, of course, if you remember, albumin holds water in the bloodstream and stuff, and so now if it's super low, you're going to get edema, so swelling ascites and all of that. So the water's not staying put in the cardiovascular system, and it's going into the tissues and all of that. And then you can also have hypercholesterolemia, because the cholesterol and stuff is not going to be filtered. So that's another one here that is characteristic of nephrotic syndrome, but especially this heavy protein loss and the low albumin. An acute onset can occur if there is a circulatory disruption to the kidneys. So if the kidneys lose blood flow, then all of a sudden they can get nephrotic syndrome. And some forms of glomerulonephritis can progress to nephrotic syndrome, and you get lipiduria, results in excretion of fat bodies, which can then be seen in the urine. All right, the next one is renal tubular acidosis. So it can be due to acquired and inherited disorders. Acquired would be exposure or damage and stuff like that, and to the kidneys, inherited or going to be more like genetics, right? So failure to reabsorb bicarb or secrete hydrogen ions is a hallmark of renal tubular acidosis. Your signs and symptoms are high chloride, metabolic acidosis, normal anion gap, and normal glomerular filtration rate. And there are several different renal tubular acidosis. So distal renal tubular acidosis is type 1. It is the most common. And in this one, you simply have a reduced hydrogen secretion in the distal convoluted tubule. Proximal renal tubular acidosis, or type 2, you have impaired bicarb reabsorption in the proximal convoluted tubule. And the type 4 renal tubular acidosis is a combined renal tubular acidosis, and you have impaired cation exchange in the distal convoluted tubule. So, for example, that cation exchange would have been those exchanges of sodium for potassium or sodium for hydrogen ions. So those are renal tubular acidosis. Okay, then urinary tract infections. These guys are actually quite common. The most common is going to be cystitis, so that's just plain old inflammation of the bladder, really what we refer to as a bladder infection, because the inflammation is usually due to the presence of bacteria. Pyelonephritis is infection of the kidney, and so pyelo refers to the renal pelvis, which is the funnel that empties the pelvis. Funnel that empties the kidney there into the ureter. And nephritis for nephrons. So there you go, and kidney also. So how do you differentiate between pyelonephritis and cystitis? You will see urinary cast on your analysis if you have pyelo, because casts are formed in the kidney and their presence indicates kidney involvement, especially if those casts might be white cell casts, so because of the white cells and stuff that are present in the kidneys. Some of the risk factors of urinary tract infections is anything that will block the flow of urine, and indwelling catheters. So if you think of all of our elderly patients and people that are in the hospital that have to have indwelling catheters, that is a high risk factor to get in urinary tract infections. So symptoms of a UTI are fever and painful urination. And sometimes some of them, it can be what we call silent, because some patients may have just a mild fever and they won't have painful urination. Here's another kind of fun tidbit for you. If your patient is an elderly, like dementia patient, their main sign or symptom of a urinary tract infection is going to be an altered mental state. So basically, I know they have dementia and they're like not normal, but they're like wackier than normal. There's something wrong. They're at a different level of crazy, basically. And that is often, the cause of that is simply often a urinary tract infection. You treat the urinary tract infections and they go back to whatever their baseline normal is. And how do you treat, of course, a urinary tract infection? Well, you would identify the causing agent and treat it with antibiotics. They often just go ahead and prescribe antibiotics that generally work for UTI while they get a culture. And then sometimes, of course, if the culture doesn't match the treatment, you would then adjust the treatment. Okay, so polycystic kidney disease is a genetic disorder and it's a progressive disease, and you get cysts in the kidneys, and it is the leading cause of kidney transplant. And so this is a kidney with a bunch of different cysts, as you see right there. And normally it wouldn't be like that. It would be nice and smooth and, kind of a dark brown in color. So again, the only way you resolve that is kidney transplant. If the kidneys get bad, if one of the kidneys gets bad enough, it might be removed. And as a fun tidbit for you guys that knew Mr. Payne, Mr. Payne had polycystic kidney disease. All right, diabetic nephropathy. So this is damage to the kidneys from diabetes. So the problem with diabetes, especially if it's not well managed, is you have chronic high glucose levels. And the glucose, the high glucose, and especially the high insulin and type 2 diabetes damages the kidney. So glucose, if you will, being high all the time is an irritant. And the nephropathy then, of course, decreases the renal function. So as the glomeruli, just where the capillaries are, it gets damaged. The kidneys lose their function, and it's very slow and very gradual. So the reason one of the things that we do, because it is so slow and so gradual, is that we use microalbumin. So this looks for traces of albumin in the urine, and it is used to detect early proteinuria before it is even detectable on the dipsticks and stuff. And the reason is, if we can diagnose it early, you can do more to intervene and try to save renal function. And so that might also prompt a non-compliant patient to become more compliant and all that if they know that now they're starting to lose renal function and their kidneys are being affected by their choices. So again, the idea here is to diagnose it early so that we can try to prevent the decline, or at least slow it and better manage the diabetes. All right, let's talk renal failure. So you can have acute renal failure or chronic renal failure. And in acute renal failure, you have several causes. It can be pre-renal, renal, or post-renal. A pre-renal cause is going to be hypoperfusion, so not enough blood is showing up to the kidneys. Therefore, there's not enough volume and pressure to create a filtrate, and so the kidneys can't produce urine. Okay, so many things can cause hypoperfusion. Severe dehydration is one of them. Massive loss of blood would be another one. Congestive heart failure, where the fluid is not, it's like in the legs and stuff like that, and the heart is not pumping right. Renal is another cause. So that means the problem is in the kidneys themselves. So any systemic or progressive kidney disease. So we just looked at, for example, diabetic nephropathy. So that the damage that diabetes does to the kidneys could lead somebody to develop acute renal failure, especially if the damage was sudden. Although diabetes tends to really create more chronic type of stuff. But an exposure to a drug that's toxic to the kidneys, or a toxin or something like that, and it just it damages the kidneys, that can give you acute renal failure. And then post renal acute renal failure is any structural abnormalities or calculi. So basically something that would block the flow of urine from the kidneys, and so calculi are kidney stones. But tumors and other things could could be in this category also. And so basically the urine can't flow out and leave, and so it causes a back pressure, and then that causes the blood to not be able to be filtered and the kidneys to not work. So once the cause is determined and resolved, the renal failure can often be reversed if it is an acute renal failure. So again, if it was hypoperfusion because they were dehydrated or had blood loss, you would do, for dehydration, you would rehydrate them, give them fluids and all that, and then the kidneys would start working again. If it was massive blood loss, you'd be doing transfusions and, trying to um, obviously stop the blood loss and all of that. For the calculi, for the stones, you can burst the stones and all that. If it was exposure to a toxin for the renal ones, you would try to antitoxins or chelate or do something to remove that so that the kidneys can regain function. And for chronic renal failure, chronic is a progressive loss of renal function. So the glomerular filtration rate steadily declines. And really, chronic renal failure is more something that you can see with, chronic diseases such as diabetes and lupus and, other, inflammatory diseases that people have long term. High blood pressure for many, many, many years will give you chronic renal failure. And so either way, the diagnosis of renal failure is you see a decreased glomerular filtration rate, an azotemia, so the high BUN, and in this case, BUN and creatinine in the blood, oliguria, that quit making urine or a very, very little urine is made, and of course edema because they're not making urine, so there will be swelling and stuff. So and we have diabetes insipidus. So diabetes insipidus is different than diabetes mellitus, different name. So this one is a failure of tubular reabsorption of water and an excretion of large volumes of urine, and you have a really, really dilute urine. And it's related to how antidiuretic hormone works. So there are two types of diabetes insipidus. There's neurogenic and nephrogenic. In a neurogenic diabetes insipidus, you don't produce antidiuretic hormone, or you don't produce enough. So my brother has that. My brother has neurogenic diabetes insipidus from a head trauma. So he slid and fell and knocked himself out when he was a kid and damaged his pituitary gland, which quit making antidiuretic hormone. And so he doesn't make antidiuretic hormone. And so he was thirsty all the time and he was peeing a lot. And so he has an antidiuretic hormone nose spray that he has to take several times a day to counter that. And then the nephrogenic DI, you make enough of the antidiuretic hormone in the pituitary, but the kidneys don't respond to it. So you have antidiuretic hormone resistance. If you parallel them to your diabetes mellitus, if you will, neurogenic would be like type 1, where there's no insulin. Here there's no ADH. And nephrogenic would be like type 2, where there's resistance. In type 2 diabetes, there's resistance to insulin. Here there's resistance to antidiuretic hormone. Now, here is like, why are they both called diabetes? Because they're obviously have two completely different mechanisms. Okay, diabetes is actually an ancient Greek term, and both diseases have the same signs and symptoms. So they have polyuria, polydipsia, and in here, of course, nocturia, which is also a sign and symptom of diabetes mellitus. The difference, of course, is in the diabetes mellitus, you also had to have a really sugary urine and stuff, whereas in this diabetes insipidus, that would not be the case. But back to the name, the word diabetes in Greek means siphon. And basically, just think of, or funnel. So like think of somebody like drinking a lot and peeing a lot, drinking a lot, peeing a lot. So they're like a funnel for water. And since that was the common sign and symptom between both, they got named diabetes. And then when, later we made progress and all that, and we figured out there was actually two different mechanisms to deal with two separate diseases, but they retained the name diabetes because it came from the common signs and symptoms. So there you go. The diagnosis of diabetes insipidus is made with a 24-hour urine to check for the volume of urine that's being passed in 24 hours. And then you can do plasma and urine osmolality and draw antidiuretic hormone and check those levels. All right, renal obstruction. So that is when the urine flow is blocked, and it can give you the post-renal isotemia and post-renal failure. The causes of renal obstructions are kidney stones, enlarged prostate, tumors, blood clots, scars, etc. For kidney stones, also known as renal calculi, they can be crystalline or solid aggregates, and the factors that promote formation are certain components in the diet. So some of them say, like with the calcium, excess dairy and stuff, and then calcium oxalate comes from tea, but there's other things that can promote the formation. Also, being chronically dehydrated can promote that, and there are some genetic factors. There's some people that are simply more predisposed to making kidney stones. And the diagnosis of renal obstruction, you need imaging, obviously, from our folks from medical imaging. So sometimes some contrast studies, but also sometimes just a simple X-ray or CT scan. On our end, we can do a urinalysis, of course, and be looking for crystals and stuff like that in the urine, and we can do BUN creatinine levels and a CBC. The white count in CBC is what you potentially be looking for. So in this case, John is 36 and has diabetes, foamy urine, foot and ankle edema, and neuropathy. His urine protein is 300 milligrams per deciliter. What do you think is his likely diagnosis? And what would be the diagnosis if the urine protein level was 3 grams or greater in 24 hours? So he's obviously losing protein. He has swelling, and he has diabetes. So those are all kinds of clues. I want you to put what you think it is in the Nearpod, and I will send out an announcement with the answers later once everybody's completed it. Okay, so some of the tests that we do. So urinalysis, you have a whole class on that, but obviously so I'm not going to spend extensive amounts of time on this, but in urinalysis, you do a physical exam of the urine, so color and clarity, the first two things that you note about the urine. Then you do a chemical exam, that's the dipstick with all the little chemical reactions, looking at things like the pH and the protein levels in blood and all of that. And then you spin it down and you do a microscopic exam on the sediment. Look at the cells. Are there red cells, white cells, or maybe you find some trichomonas or something in there. Bacteria, yeast, cast, crystals, all of these things. And the epithelial cells and stuff like that too. Anyway, report all those out. And the purpose of a urinalysis, of course, is to aid in the diagnosis of disease. You can use urinalysis to screen a population for diseases and to monitor the progress of a disease, especially, let's say, if you're monitoring the protein levels via the dipstick or something like that. And the electrolytes, so we can measure the electrolytes, which are your sodium, potassium chloride, etc., in serum and in urine. And with the urine sodium, it reflects the integrity of the tubular reabsorption function. So if you have a high urine sodium, that means you are not reabsorbing your sodium back into the blood, and that can be an indication of problem with tubular reabsorption function. So a lot of your nephrologists will like to order your serum and urine measurements, and usually want them collected around the same time, or at least in the morning or something like that, so you can see exactly what's going on, kind of get a snapshot of what's going on with a patient. Okay, blood urea nitrogen, also called BUN, or sometimes urea nitrogen on the lab reports. So what is urea nitrogen? It's the end product of protein catabolism. So you're always turning over protein, which means you're always making urea nitrogen. And It's freely filtered by the glomerulus. It is a waste product. It needs to be removed from the body. And we measure it being a waste, just because it's an indication of kidney function. It doesn't really serve a purpose beyond that. Like I said, it's just waste on its way out of the body. And so anything that decreases your glomerular function will increase your blood urea nitrogen. So there are several laboratory methods. There's some coupled enzyme methods, colorimetric methods, and conductometric whatever methods. So we use usually enzymatic and color methods are the mostly used for BUN. The BUN levels will depend on your urea concentration, right? Glomerular filtration rate and hydration levels. So they can fluctuate. So if you're dehydrated, your BUN will go up. As soon as you rehydrate, it'll go back down. And then, of course, if your kidneys aren't filtering it, it will be elevated. And then urea concentration could simply also be related to your protein turnover and how much protein you're eating and stuff like that. So those are all factors that play into your blood urea nitrogen level. Uremia is an increase in urea, in blood urea nitrogen, and azotemia is an increase in BUN and other non-protein nitrogenous compounds, such as like creatinines and other waste products. Uric acid is another one. So azotemia, just think of increased amount of wastes in the blood. And uremia is urea in the blood. So prerenal azotemia, so increased amount of waste in the blood because of a prerenal cause. So prerenal means before the kidneys, and it's due to a decrease in renal blood flow, just like we saw with the renal failure stuff. So causes are congestive heart failure, shock, and dehydration. And shock is usually a decreased blood pressure. There's all kinds of different causes of shock, but one of the hallmark of shock is your blood pressure drops significantly. Low blood pressure means low blood flow to the kidneys, means not enough pressure to cause urine to be formed. Renal azotemia is associated with kidney disease, so the kidneys aren't working right. That's what it causes renal. You have a low glomerular filtration rate, so less urea is excreted in the urine, and therefore more is accumulating into the blood. And then in post-renal azotemia, it's after urine formation, so it's usually due to obstruction. So like we saw a few slides ago, tumors and stones and stuff like that. All right, creatinine. It is a waste product of creatine, and creatine is related to muscle function and muscle mass, used to make creatine phosphate, which is a storage form of ATP in muscle. So creatinine production is constant, and it is related to muscle mass. So, but it is constant, like as in it doesn't fluctuate within 24 hours and stuff like that. So it's steady throughout the day, constant production. It is also freely filtered by the glomeruli. There's no reabsorption. And so this is why it's used to determine renal function and the severity of damage and to monitor progression of kidney disease, and it's often ordered with a blood urea nitrogen. The lab methods are the Jaffe reaction. You might want to remember that because that's somebody's name, basically, and the board questions love to ask questions about methods that are named after people. So Jaffe reaction is creatinine. And in that reaction, picric acid reacts to form a red-orange chromogen, which is related to, in proportional to the amount of creatinine in the sample. In the BUN creatinine ratio, and so on that one, there's not info in the book, which I hope that in the second edition she changes that. But that's why I included the extra information sheet for you guys. So it's the ratio of BUN to creatinine. Normal is 12 to 0 to 20 to 1, or you can say 12 to 20 in some lab reports is what they'll put. And the interpretation of the BUN creatinine ratio can help you kind of determine what kind of type of azotemia is going on. So in renal azotemia, the ratio is usually normal. So like a 12 to 0, whatever, but you'll have high levels of both BUN and creatinine. So normal ratio, but high BUN and high creatinine. So, for example, if you had a urine creatinine ratio of 10, and then but a really high BUN and high creatinine, the thing is because they rise proportionally, the ratio stays normal. So that would indicate problems with the kidneys, renal azotemia. In pre-renal azotemia, the ratio is always greater than 20 to 1, and oftentimes in pre-renal azotemia there's a normal creatinine. Now you could have a slightly elevated creatinine or slightly high and still have pre-renal azotemia. Just if that ratio is above 20, we're pre-renal. So we think dehydration, loss of blood volume, shock, and that kind of stuff. And as soon as you correct that, usually the azotemia corrects itself and the BUN creatinine ratio goes back to normal. And in post-renal azotemia, your ratio can be greater than 20 to 1 with an increased creatinine, or it can be normal also sometimes with increased creatinine. So it's a little bit, the handout has a little bit better cutoffs and stuff in a table, so you can go back and refer to that. So there's some room for interpretation in those. Just think of them as simply kind of helping you to guide you into figuring out what's going on with your patient and what's going on with the kidneys. The creatinine clearance is another test that we do. I'm sure if you've had urinalysis, you've heard about this one. So you have to collect a 24-hour urine and then collect a serum creatinine sample during that time. You can have collection issues. So some of the problem is you're supposed to get absolutely every drop of urine that it produced for that whole 24 hours. Well, all it takes is somebody not knowing what's going on that come in and dump the urinal if it's a male or whatever, and then you're missing some of the urine. So that can happen sometimes with well-meaning family or patients that don't understand what's going on, or stuff can get spilled. And anyway, there's all kinds of ways this can go wrong. But the idea is the way you collect it is you have the patient completely empty their bladder, and that's time 0. And then you start timing 24 hours from that time, and then every urine that's produced needs to be collected and put in this big jar and put on ice and stuff like that. And then at the end of 24 hours, hopefully you have them empty the bladder again. That goes in there, and hopefully you've collected everything, and then you send that to the lab. And it is useful for approximating the glomerular filtration rate. The formula is the urine creatinine times the volume divided by the plasma creatinine, and times 1.73 divided by the body surface area of the patient with their normalization factor. And there's also in here with the normal time and all of that. There's that gives you the creatinine clearance in mil per minute per 1.73 square meter. And so that's 1.73 is the average body surface area of a human being. So obviously it varies from one person to the next. So anyway, urine over plasma, if you need to remember that, and times the volume, and it's usually the 24-hour volumes divided by 1440, which is the amount of minutes in 24 hours. I think that's what it is. Anyway, so there are formulas out there. You can always just look it up. It's not too hard to memorize that. All right, uric acid is end product of purine metabolism. Purines are part of your DNA and RNA. So the more DNA, RNA turnover you have, the higher your uric acid is going to be. Elevated levels can cause kidney disease or kidney stones because the crystals can damage the kidneys, and of course then crystallize and cause stones. So the causes of hyperuricemia are gout and increased nucleic acid turnover, so increased cell turnover. That means usually an indication that there's a lot of cell damage going on. Or it could be a leukemia, or you're getting chemotherapy for leukemia, something like that, or chemotherapy that's destroying a bunch of cells. And anyway, if there's a lot of DNA, RNA turnover, you're going to have high uric acid. And the lab method for measuring uric acid is an enzymatic method with uricase. So there you go. Again, this is another waste product that's just indicative of some, other things going on, and we measure occasionally. All right, urine protein. The proteinuria indicates renal disease. So we measure urine protein quite often. Again, it can be due to glomerular loss or tubular loss. And glomerular loss can be from damage or from if you had overproduction of those Benstrone's proteins and stuff. So the urine dipstick results are sensitive to approximately 30 milligrams per DL of protein. The automated chemistry urine protein is sensitive to approximately 10 milligrams per DL of protein. And you can do urine protein on a 24-hour urine or on a random urine. And the lab methods for urine protein are turbidimetric methods to determine that. So your osmolality is the number of dissolved particles per kilogram of water. We've covered that already in method or instrumentation chapter, but it's a measure of urine concentration, and the docs often order serum and urine osmolality so that you can compare and see how well the kidneys are concentrating the urine. It is useful in diagnosing diabetes insipidus. And of course, again, like I said, you would want the urine and the serum levels performed, and like on the same day, ideally. And then lastly, how do we treat all this? Hemodialysis and peritoneal dialysis are the end-stage renal disease treatments. Hemodialysis substitutes for the kidneys and waste product removal. So that's what you see right here. So the machine here is pulling the blood out, filtering it, and then putting it back in. And so this dialysis machine, is doing the work that the kidneys would normally do. So they have people that are on hemodialysis have to do it several times a week, usually every other day or something like that. And then your peritoneal dialysis uses peritoneal blood vessels and basically to wash the peritoneal fluid. And so you get your dialysis bag, and it puts the clean fluid into the abdomen, kind of washes it out and removes the waste. A little less involved in this, and so it works for some patients, but it kind of depends on their level of failure and stuff. So you're liable to see both of those. So, and there you go. That is the end of your presentation. I appreciate your patience, and you guys have a wonderful day.